Hey everybody, can everybody hear me? I'm Dr. Carly Brown. It's Facebook Live lunch. Um, I know some people have some questions, so I wanted to answer them today. Let me see. Okay, no, everybody can comment. If anybody can't hear me or see me for whatever reason, please let me know because I can't tell from here. So we've had some exciting things coming up at Ashewell. If I look tired, there's a reason. It's because we've been working really hard to get a very exciting study up and running. And, the study is going through IRB approval right now, and that should be done in a couple days. But until then, I can't talk about all the details, but that will all be disclosed eventually. But the real idea behind the study is to kind of determine what the prevalence is of COVID-19 in a certain population in our community. The population happens to be the adults that go to Ashewell Medical Group. It's a great population to follow, and we have the ability to follow them over time, which is unique in a practice. And that's kind of where that comes from. I have some benefactors who are helping us with the study, and we joined up with a researcher, a neurovirologist by the name of Dr. Robert Yolkin, or Bob Yolkin, and he is a neurovirologist and a pediatrician at Johns Hopkins. And he has a specific interest in viruses. So we joined up with him, and as a team, we have designed a study which looks at some of those questions, which is, what's the prevalence of COVID-19 in Asheville right now, in Buncombe County, even in Western North Carolina? We don't know for the most part. We can guess, but it's based at this time on a limited amount of testing. And in order to have a really good idea of what that is, you have to test a much larger population, right? And you have to test everybody. You can't just test sick people and high-risk health workers and so on and so forth. You really need to test everyone. So that's kind of the goal, is to get some idea of what the prevalence of disease is in the community. But we also have a questionnaire in our study, which is very extensive and kind of fun to answer. And that questionnaire, which I designed, will really kind of look at the epidemiology of our community, and we'll be able to see who's getting disease and who's not, and that way hopefully identify vulnerable populations. I'm turning off my phone. I'm sorry, it's so annoying. And please excuse me because I woke up this morning unable to hear out of my right ear. I must have eustachian tube dysfunction in this ear. I don't really have allergies, but clearly I do it today. So I can't really hear myself that well, which is why my sound kind of weird. And I apologize about that. But so the study will ask questions about, demographics, right? So, how old are people? Are you married? How many people live in your home? Have you been sick? Are you sick now? What were your symptoms? What are your symptoms now? Things like that, right? Are you a healthcare worker? Are you working? Are you not working? And these things will kind of give us a lot more data, and we'll be able to kind of check. The other question that we're getting is, why are we testing with two methods, right? So we're testing, so we're doing the questionnaire, and then we're doing an antibody test. And the antibody tests are the tests that are kind of controversial in the media right now. No tests are perfect. I don't know what the drama is. I really don't. But you obviously don't want to give garbage tests. That's ridiculous. But obviously you want some testing, right? So in the fact that we've developed these tests in the last 8 weeks, they're probably not going to be perfect. That's the first step, right? And also I think there's a lot of control going on of the market by unsaid forces, and I think there's some probably pretty good decent tests out there that are not really being allowed to be done because of reasons which we shall not mention. But in general, our tests are very good. They're not FDA approved yet. They should be FDA approved within the next week, and that's great if they are. If they're not, we're going to do it anyway because it means nothing. The data shows that they're pretty sensitive and specific, about the same as like a flu test or a strep test, something like that. And what we're going to do in order to make the results as kind of true as possible and as accurate is to test with PCR. So PCR is where you look for virus, actually, viral RNA, and then it's turned into DNA, and then it's amplified so that you can recognize it. And that's how you find virus through PCR. It's a very simplified kind of explanation of it. But the antibody tests look for antibodies. So when you get sick, when you're exposed to something, you make antibodies, right? Which are these proteins which say, I either have the virus now or I had it in the past, right? Or maybe I'm somewhere in the middle. And the antibody tests kind of do that. They kind of, through showing whether you have IgM or IgG antibodies, say, do I have the test now or did I have it in the past? And that's very useful, right? Because it kind of tells us the sequential progression of disease, when you make antibodies in what phase of disease. And with time, we'll have all that data over larger populations. It'll make a lot more sense to us now at that time than it will now, of course. But that doesn't mean we can't collect the data, right? We still have to do the test. And the answer, I have a really good question, which I think is very astute, is that what do they tell us? What does the antibodies tell us, right? So if it's, does it tell me I can go back to work? Does it tell me I can, go see my mom? No, it doesn't actually tell us that at all, okay? We hope one day to know whether or not the antibodies that are found in COVID-19 convey immunity. And what that means is that if you have antibodies, that you cannot get COVID-19 again. We don't actually know that right now. And then we don't know if you have antibodies, how long they last. But in order to find that out, we have to test, right? So we have to test now. We probably have to test again in 6 weeks, 12 weeks, 3 months, which is what we're going to do in the study. Okay, maybe 6 months. So we have to kind of test at intervals to be able to see what happens with people's antibodies, right? Because, we have some diseases where you get antibodies for life, right? And you have so many diseases that you don't. And you have some diseases where you get antibodies to certain things at life, but not other strains, right? So that's interesting. And we know that other people are exposed to coronaviruses because there's lots of them. They're exposed as children, they're exposed as adults. And these antibody tests are good, but they're not perfect. They can have cross-reactivity. The ones that we are using have a low incidence of cross-reactivity of important things. So we feel good about that, but they're not perfect. Just total honesty, right? They're not perfect. So what we're going to do on the backside is we're going to also test with PCR. So antibody testing is done where you take a finger stick and you're testing your blood sugar, and you get a little, finger stick and you get some blood out, a little drop, and you take 2 of those drops and you put them on this little pipette. You take the pipette out, which is like a little baster, a miniature baster. For those of you who cook, it's a terrible explanation. I don't know what I'm thinking. But anyway, it's a miniature baster, and you take the drop of blood up, and then you put it on this kind of like little cassette card, which is exactly like what we use for strep testing or flu testing. And you put the blood in there, and then it develops, right? And it runs, and it gives you kind of an idea of whether you have IgM or IgG antibodies or mixture of both, or so on and so forth. And there's a control on that little thing too, so that you can see if the test is working correctly as much as it works correctly. And then on the backside, we're also going to do a PCR. And that means that not only will we take blood out of your car when you do the drive-up testing, but we'll also swab your throat for virus or viral RNA. And that will be sent to Quest. And those results will be done in maybe 3 days. So the antibody test is a rapid test, so that'll be done in 15 minutes. And actually, we will give those results on site at the time of testing. Okay, so you'll basically go through a series of stations, right? Everybody will register for the entire study prior to the event, right? So we have a website up that's being developed as we speak. And what happens is you go on, you sign our informed consent, then you will be directed to the questionnaire. And if you want to participate, participation is completely voluntary, and you can drop out at any time, and your care will never be compromised if you choose not to participate or you decide to stop participation. There's no question about that. But if you sign up, you want to sign up and you want to get through the informed consent, then you will get through that. You'll sign, then you'll get a copy of your informed consent automatically. This is very expensive to build, and that's part of where the funding is going to, is that it's complex. We know in a time like this, we can have papers going back and forth. We wanted to design something that was safe and also reproducible, so other people in other communities could do it, which is pretty cool. And so we're building that website right now. It's pretty much almost done. And then once you get through the informed consent, you'll get a questionnaire. And I think the questionnaire is like maybe 25 questions or something like that. It's not extensive. You fill it out online, and that's pretty much it, to be honest with you. Yeah. And you also have to give your personal health information on a different form that comes before the questionnaire, just so you know, but they're on different forms because we're going to pull the personal health information away from the data. I will be the only person who will see the connection between those two, and they will be stored in separate places from the data. That key will be stored in a separate place from the data. The data will go out to Johns Hopkins, but they will not see any of that personal health information because confidentiality and privacy is of the utmost concern. That is being overseen by the Institutional Review Board, for which we have applied, and hope to get, an answer pretty soon. And so this is for real. This is, legit. Everything goes onto secure websites, and all the data will be on secure encrypted laptops and things like that. So as you can imagine, this is quite a large undertaking. So after you've completed your enrollment, you will then eventually we'll give you a time to come to our drive-by site. That will involve like 3 stations. We've hired amazing nurses, and I will be there, of course. And I think actually a lot of our team will be there. We'll have to close the office. And when I say close, meaning we'll always be available for urgent matters. As you know, we are right now, and answering the phone and everything like that. But we'll probably not be on site in the office, which we are today, as you can see, and every day, but we will be at the drive-through site. So that we'll be there, and there'll be kind of 3 stations, and you'll drive up to one. And that's where you'll be de-identified. So you will check in with one of our staff who knows you, and you'll be given a bracelet, right? And then and they'll label that bracelet and the labels for your specimens with a number. And then you'll go around to another station where a nurse will do your finger stick in your car. You stay in your car the whole time, okay? And they're outside in full PPE, and they'll do your finger stick, and they'll take 3 little drops of blood for you. The 2 drops will go on the antibody test. 1 drop will go on a blood card. The blood card is what's being sent to Johns Hopkins. The blood card is this extremely cool thing where you can kind of like pull tons of information out of these blood cards, but we're using them specifically for this identification of viral mutations specifically. So for example, we've been seeing a lot of false negatives in COVID cases with PCR. And there are some studies that estimate up to 30%. And the reason why is because there are mutations, right? And that genetic sequence that the PCR detects is very specific. And if you have, these kind of mutations, it's not going to be as easy to pick them up. So what the blood card does is it gives us the ability to go back into those sequences and see why you may have had a negative PCR, even though you actually have we suspect symptomatic COVID disease, right? So, and what that will allow is that eventually to develop more sensitive testing, right? That's very important. We need to know why people are getting sick, why some people are getting sick, why some people are not getting sick, why some people test positive, why some people do not test positive. All of this information is paramount, so important in order to be able to get where we need to with COVID-19. So that's why we need that information. All of that information will be totally de-identified, meaning like there will be no way for any of the researchers to go back to identify as to an individual, right? There will be no personal health information included there. But it will be available for studying. They won't be able to go into your genetics or look at your color of your eyes or, where your grandparents were from. That is not what's happening with this. This is a very specific use, and that's what it'll be limited to. But it is very cool. And because the neurovirologist at Johns Hopkins, Dr. Yokin, is helping us, obviously, he's weighed in on this and said that's what we really need. And we're totally on board with that, which is very cool. And so you'll go and you'll have all those things done, and then you'll have a throat swab, right, which is our Quest test, which is where you're swabbing, and we get viral RNA from that, and then it allows us to see whether you actually have virus. And that's important to compare to the antibody test because we want to see how accurate the antibody test is, right, and how accurate the PCR is. That gives us some idea of that, right, and how those relationships. And then eventually you'll drive into another little section and you'll just wait. And those tests will develop over 15 minutes. We'll give you the antibody test, and then probably about a week later, we'll call you with your PCR results as well. And I am obviously your doctor, so I know you for the most part. And I will be there for questions, basically infinite, for the end of time. And there will always be the opportunity to answer your questions or whatever you need for the most part. So that's kind of like the basis of the study. And then the other cool thing is that everybody gets tested, right? And everybody gets an opportunity to know what their status is. And at this moment, maybe not forever, but now. And I think that the opportunity to do this was kind of hard to pass up because it really does advance our knowledge of the disease, of the epidemiology of it and moving forward. So that's extremely cool. Some questions I had is, do nasal swabs hurt? I don't think they're comfortable. We do them to children. They can sustain them. We do them to adults and they can sustain them. It's just like a flu test, So they're not comfortable, but I don't think they hurt. They just are not pleasant, right? Your eyes water a little bit. You have tissue and yucky, right? It's a nasal swab. But we're doing mostly probably oral swabs, which is throat swabs, just like a strep test. And those don't hurt either. You can gag a little bit uncomfortable. But there's just really, it's just a very minimal risk associated with those. Okay. So that's kind of what the swab is. Do the finger sticks hurt? They're going to hurt a tiny little bit. That discomfort is limited. Go away in a couple minutes. A little pressure, no bleeding, you're done. The other question was, where is the money that we're asking for going? So I don't know if everybody here knows this, but we put up a PayPal donation button on our website yesterday. The reason being that we wanted people to have the opportunity to donate, to contribute to the study. The study is very expensive to do. So where's most of the money going? So we had the antibodies tests donated to us by the company who manufactures them. And the PCR is going through Quest, and that is the expensive part. It's actually gotten more expensive than it was a couple of weeks ago, but that's another story. And so that's what we really have to pay for. That's the bulk of things. Now we also have to pay for, obviously, hired nursing, and everyone to pay everybody, a decent wage, right? So hire nursing and the tents, the site possibly. We don't know where that's going to be. It's going to be one parking lot. Hopefully it'll be free, but so on and so forth. All of the everything that comes with it, right? So all the paperwork and the websites and the surveys and there's boxes in here of stuff like, things we have to mail in, has to have biohazard stickers in. It's just a whole to do. So it's expensive. And so we think that it'll be about maybe 200 and 250 per person. We're only really asking money for the $100 for the PCR. We have other private funding for the other part, or some anyway, and we're just kind of trying to make up as much as we can. We're going to ask for more money either way for grants, to try to get all this done. And there's none of the investigators are benefiting financially in any way. Ashewell's not making money. Johns Hopkins is not making money. Nobody's making money. But the point is that, we want to be able to not lose money. That's kind of like, key factor here. We can't go bankrupt testing our Ashewell population. But other than that, that's where the money is going to. And it's mostly the PCR because it's so expensive. And everything else is expensive, but it's stuff that you can easily get grant funding or private funding for. It's the PCR that's very costly. Let me tell you what else, what other questions you had us. Oh, somebody asked me to try to post this on YouTube, and I will. I'm happy to do so. I always think, why would anybody want to watch me on YouTube? But if you'd like me to, I'm happy to. And that's pretty much it. Does anybody have any questions for me? I hope everybody's well. I didn't bring my lunch yet, but I will eat it in a little bit. If anybody has questions, you're welcome to email them to me. Again, the study will be open to adults of Ashewell Medical Group, 18 years old and up. To do children was one, I think, unnecessary, and also unnecessary, and also it was a lot of parental kind of like, we had to have like consent and stuff like that, and it got complicated, and it's already complicated, and we're not, a huge organization to set up these massive studies. Already to test maybe 500 to 900 people is a lot for us. So we just didn't want the complication of that. And we have such a small percentage of young people at Ashewell, 14 to 18, that if I need to offer them testing in another way, I will, but it just won't be part of the study. Can you volunteer? As a patient, no, we can't have anybody but the Ashewell Medical Group population do that. And that's because of malpractice reasons. And also because we can follow the Ashewell population. Can you volunteer in other ways? Maybe. That's very possible. I just don't know. If you want to email me at drbrown@ashewell.com, I can tell you. But we certainly appreciate you offering. And I think that, again, that has been a lot of, we've had to like figure out about liability and malpractice and everything like that. And so that's just been a lot of stuff to do. It's been very time consuming. And I've slept about 4 hours a night for the last 2-3 weeks, trying to write the IRB protocols and the informed consents and everything that needs to go into a process like this, which is very, very labor intensive, but very exciting. And this is why we're doing it, right? Because we think it's really, really great information that we need to have. And the other thing is that we're not closed off to potentially opening this up to an open population after this, but this is kind of a very good dry run because all my patients, they know us, we know them. This will kind of give us a dry run to see, what the logistics are, how quickly we get back the results, just all sorts of questions that I want to make sure it's done right. And then once it's done this way, which I think it will be done correctly because of all the work we're doing, then we might roll it out to the general population. But we won't be able to do that until at least we have some testing done first, is my kind of feeling. Always do something well. Can't go crazy. So that's first. And then the other thing is the expense. So if we were to roll it out to the general population, one, how would we pay for it? And if we build some of it to insurance, or the lab build to insurance, which is a possibility, it just gets more complicated. Dr. Bartow and I are opted out of Medicare so that we don't get accused of double billing Medicare, because, that's never a good thing. So that is a challenge, but it might be okay. I just don't know. And also, we don't have Medicaid licenses, so we want to make sure all that's okay. What we might do is hand the protocol off to somebody who does have all those things in place and can help us do it. Because we think that really the more varied the population, the more equitable in the recruitment of study participants, the better the study will be. So we would love to have more of an open population. That would be great. But let's get this dry run first of the Ashewell patients, and then go from there and see how we do, which I think is going to be amazing. Does anybody else have any questions? No one? Okay. Well, again, you're welcome to email me. I see some of your questions or some of your comments here. Thank you very much for everybody for joining us. Again, if you like another Facebook Live at another time to answer more questions, you have any come up, I'll save them and I'll answer them going forward. Somebody else also asked me about oxygenation in the morning and night. They said, will your oxygen levels be different in the morning and night on your pulse oximeter? I'll just answer that here. And the answer is they shouldn't be. I don't know why they would be. You shouldn't have less oxygen in your blood at one time in the morning, but more in the night. That doesn't make any sense to me. My suspicion was if you feel very well, that probably it's with your pulse oximeter. When you use those pulse oximeters, you have to make sure that they have a waveform. Let me go get one so that you can see that. Okay. So just to review. So this is a pulse oximeter here. Okay. Oh my gosh. Okay. So this is a pulse oximeter. Okay. And I call these like chip clips for fingers. Okay. My kids love these things. And they have a power setting, and you put them on the end. They do not work well if you have nail polish on or long fingers. So, or any sort of like acrylics or gel or things. You got to have like boring fingers like mine. And you can see that they will give you an oxygen level and a heart rate. Okay. So this one doesn't have a waveform. I don't know why my heart rate is so high. I think it's because I drank too much coffee this morning to make up for my ear that I can't hear out of. But you can see I have a lot of oxygen. I've got 98, 99. Leave it on for a few minutes, right? And then you can see it's picking up my heart rate. It's kind of got this one's a little bit different. Usually I have the ones with the waveforms, but this seems pretty reliable to me. See the other one. The other one is the same. Sometimes you'll have like a waveform on them, and it'll kind of go like this. If there is not a waveform on them, it is not accurate. You need to make sure you're taking a reading when there's a good waveform. Okay, so that's one of the reasons that might be problematic, or if you have nail polish on, that might be another reason why you don't get good, accurate results. But I can't think of any reason why your oxygen levels would vary. And the reason, what's one interesting thing is about the pulse, like why pulse oximetry, right? Well, pulse oximetry is interesting because it measures the oxygen in your blood. And what we see in patients who are COVID-19 positive is that their oxygen levels are very low, right? But they don't always realize it, because they have other symptoms going on, maybe nausea, vomiting, diarrhea, fever, muscle aches. They don't sense any shortness of breath, so they don't test their oxygenation, and maybe they don't have a pulse oximeter. What ends up happening is by the time they get short of breath, their infection in their lungs is already pretty significant. It takes them to the hospital, and then they check their pulse oximetry at the hospital, and their levels can be as low as like 50%, which is crazy. I mean, it's so low. And we don't normally see that, in a person who's on their cell phone. It's just very, very odd. And that's because COVID-19 seems to cause something called silent hypoxia. And what happens is as the virus kind of like basically gets into those lungs and it causes like a stiffness in them as a result of the depleting surfactant, which is what keeps those air cells open, you will get less expansion. And so you will automatically adjust without knowing your breathing rate, right? I think what it is, and like longer, deeper breaths. And because you're continuing to expire your carbon dioxide, you don't sense that shortness of breath. I think I'm getting all this right now. I just don't have my notes in front of me, but that's exactly what happens. And so you don't sense that shortness of breath. But as it gets worse and worse and worse, you will. And by the time you do, that's when your oxygen levels are extremely low. And that's what takes people to the hospital normally. And the good news is that, once we can get you on oxygen and potentially position people in the hospital in these prone positions where their lungs are able to expand better, we can oxygenate them. And like I've seen stories of people going into the hospital with, oxygen levels of 50, going to prone position with oxygen support, and then being able to bring their levels up into the 90s. And actually the rate of putting people on ventilators has significantly decreased since they have kind of come to that discovery. And we really want that because when you go onto a ventilator, it can be quite dangerous, right? So there's a lot of risks associated with putting anybody on a ventilator, which is why we want to not do that if we don't have to. And very early on in the disease, there was a lot more people put on ventilators. And it is perhaps one reason why we saw more fatality earlier. It could also be because people are sicker. That's a very hard number to determine and it would have to be studied. But if that is the case, now we're seeing a much lower rate of people being put on ventilators and requiring that in like our big hotspots, essentially. And some of it has to do with our ability to oxygenate people better without ventilation. And so I had cited this New York Times opinion piece a couple of days ago from Dr. Richard Levitt then, who was an ER doc, and he had talked about pulse oximeters and how if you had one at home, you could really do well for, and knowing what your oxygen levels were doing because you would be able to determine that your oxygen levels were falling before you really had that shortness of breath that brought you to the ER. And treating you early could potentially reduce your risk of going onto a ventilator. And that's what the article was about, which I thought was very interesting in itself. So that's why we shared that. But so anyways, these used to be like ubiquitous, like $20 on Amazon until about, 6 weeks ago when it became everybody wants one. So, but that's kind of unfortunate. So, but anyway, they're hard to get a little bit now. And I've seen them at for $60 to $80, which is ludicrous. People ask me, how do I buy? How do I know which one to buy? We buy ours from professional sources, but I will tell you that you can buy pretty decent ones on Amazon. And usually the way I choose is I look for the most 5-star reviews. Like if it's got 1,400 5-star reviews, I'm into it. And I choose blood pressure cuffs the same way. It's extremely scientific. So that's it. Okay. Anybody have any other questions? No? Okay. It was nice talking to everybody. Thank you for joining. You are always welcome to email me at drbrown@ashewell.com. We are very much looking forward to putting this study together. I'm looking forward to seeing everybody, to be honest with you. The drive-by is so exciting for me because I can see everybody and say hi, which is hard. It's hard not to be able to see everybody. We miss you all. We worry about you. We think, how are you doing? How are your families doing? It's just part of what we do, right? So we're looking forward to getting back to normal. I cannot tell you that this test is going to do that. And I do not agree with relaxing social distancing. I'm just going to straight up come out there and say that. We do not have testing enough to do it. If we had more testing, we would be able to do it, I think, if we had a really good idea of what the prevalence of disease was in our community. Nobody wants to open up more than I do. This is not that fun. No, I'm ready to go back to our old life. I liked it. I liked it when my kids went to school. That was good. That kind of worked out well for me. And I liked it when all my employees were here. All of the Ashewell's employees are still working. And without any change to their pay, we are working, but most of us are working from home. Only Kelsey and I come into the office and we practice social distancing at the office. But for the most part, everybody is doing okay, and we missed you guys, and we would like to go back to our normal lives too, but we are very fearful about opening up too early. I think you put a lot of people at risk that way, and we have done such a good job here of social distancing so early and stay home and stay healthy. I really think Buncombe County's done an amazing job, and I'd like to commend that. But I think that relaxing standards too early is puts us at risk for a second surge, which is much worse than the first one. I have been seeing cases pick up in the last few days. These are not diagnosed cases. These are patients who are just quarantined, but I've been seeing some whole families get infected. And what I worry about is that the community spread is so extensive at this point that it will take very little once we relax those social distancing practices just to up go the number of cases, right? And I think that is a bad, because the other thing that our study will do is once we know kind of the prevalence of disease here, and and we can possibly expand those numbers to our population, we can also estimate fatality rates, which is a good thing. It kind of gives us an idea of really what is the fatality rate of COVID-19. It was actually it should go down the greater your prevalence is, right? Because if you're detecting a lot of asymptomatic seropositive patients in the community, that means that do not die, and thankfully, then your fatality rate should go down, which is really important data to have. So that's the other reason why we really need to do these studies. And we're just excited that we can be part of anything like this, because it's a little bit different than our day-to-day, but we're into it. So it was nice to see everybody, and I look forward to seeing you again soon. Please stay home. Please wash your hands. Please practice good cough and sneeze etiquette. All of these tenets just stick, right? They are what they are, and we have to adapt. And I'm the first one to hope that we will adapt quickly, but let's listen to our scientists out there. Let's listen to Dr. Fauci. Let's listen to Sanjay Gupta if you'd like to listen to him. But these are the people who are speaking the truth and who are taking into account what researchers and data is saying from all over the world. The World Health Organization, they wrote a protocol actually, and we pulled a lot of our protocol off of theirs, and we were very grateful to them. And they did that so communities like ours could test. Right? They took the bear of that and they kind of worked on it, and then we went ahead and we kind of adapted it for our needs. But we're very grateful to them and all the work that they're doing as well, because I think this is quite an endeavor, a thing to get over, and I know that they're working very hard at that. Okay. So I hope everybody has a great lunch. Okay, and please let me know if you have any questions.